Thank you for joining us this morning for Science Sunday. Just making sure Mary and people online can hear us, okay? Yep. Okay. We are going to have a few talks this morning. Neil Corman and I are going to give the first talk, and then we're going to have talks from Dr. Sullivan and Dr. Hawk. And then we will split up into groups and be able to tour a couple labs. And we will have a group in this room as well to have some informal discussions with Dr. Hawk and Dr. Sullivan and ask sort of all the questions that you might have about research processes, maybe what you see in the lab, you'll have some additional questions about. So we hope that today is interesting. Please ask all the questions that you want to be able to really understand some of the concepts that we're discussing. And I think the other thing that I think about in closing the meeting in this Science Sunday way is that I feel like when we hear about this amazing research that's being carried out by such dedicated professionals in the field, like those of us those in the room in front of me right now, it gives me, and I hopefully you as well, so much hope. There's so much promise, there's so much happening in the field right now, and so much to be excited about. So I hope that we're all left with that sense of hope for the future in today's discussions. So please ask questions to make sure that that you understand what you want to, so that we can all hopefully leave with that sentiment. So Neil, why don't I'll hand it over to you to introduce yourself, and then we're going to sort of tag team this first presentation.
Thanks. Good morning. So I'm Neil Corman. I live in Denver. I'm a patient/survivor of ocular melanoma, was diagnosed 3 days prior to Christmas in 2016 with procedure happening in 2017 in that regard. So a little over 7 years out since that procedure with Dr. Hovland. I joined the steering committee for the vision platform that we'll be talking about this morning. Pretty much sort of after the event in Tampa last year, sort of mentioned some items to Sarah, and she said, hey, do you want to join the steering committee and provide that input? So my background is IT. I've been doing that. I also do photography full-time. So side hustle full-time when, keeping myself pretty busy. So as Sarah mentioned, we'll be walking through the vision platform this morning and highlighting some of the data and ways that you can get involved with the platform.
Okay, I'm going to start by taking us through just a little bit of the history. And for some of you who heard me talk in the intro, some of these slides are a little bit of a repeat, so I won't belabor them. I'll go through a little bit of the history of vision, and then Neil will take us through some of the data. So let's see if I can move the slides forward. Okay, are the slides forward on your end too? Yeah. So as most of you probably know by now, I am an internal medicine physician, but I did not get into the ocular melanoma field because through medicine. I got into it because of my husband, Greg, who was diagnosed when I was a third-year medical student, and he was a psychology intern. And we had never heard of this disease before and could not access any information about this disease. There were no groups, there were no websites. And this obviously, as all of you know in this room, turned our lives upside down. And we felt like we needed to advocate for Greg. And in doing so, we decided to change that, move that advocacy for the field in general, because we were exposed to people like Dr. Keith Flaherty, who is at MGH. And this is a quote from him that he said to us early on. The ophthalmologist who treated ocular melanoma didn't know the oncologist who treated it or the researchers who studied it. And we thought, oh, it's not just us as a patient and a caregiver who feel alone and isolated, and we're not talking to other people. Even the people treating this disease feel like they don't have a sense of community. They're not talking to each other. And so that gave us, I think, additional motivation to try and organize the ocular melanoma community. And so it has been, we formally launched CureOM in October of 2011. And it's been, growing ever since then. And one of the things that we heard a lot at the patient meetings and at the science meetings over the years is that we need the patient voice to be more central and louder, and we need to be able to follow patients. And that there were these registries that had patient information in this state, in that state, at this institution, at that institution. But there was nothing that was bringing all of that information together, and that the field really needed something to do that. And we were hearing this year after year. And so, so this is a little bit of background of CureOM that I think I went through these slides earlier, so I'll quickly go through this. But as you all have been exposed now to the mission of CureOM, really looking at advocacy and education, and what we're talking about today, research. And so what we were hearing was that we were advancing and supporting patients with education and support, and we were advancing the advocacy agenda, but we really needed to do more of having the patient voice be central to research. So just to contextualize that within the CureOM initiative, I think the next few slides are actually about CureOM, and some of you may have seen these the other day, so I'll go through them sort of quickly and then get back to vision. So from those early days of feeling so isolated and alone, these are some pictures from over the years at different MRF and CureOM events. And I hope that this level of community and energy you are all feeling today. And it isn't always possible, as we were talking yesterday, to have it always be in person, just because we are a small community. But whenever we can bring people together in person, we try and do that. And then, of course, we have a lot of virtual options, which you've heard from Ryan and Miriam over the past couple of days. So you've heard about the patient education and support opportunities. You're sitting at the backbone of that, our annual patient meeting. So thank you for being here. And if you have any questions about any of these other resources, don't hesitate to ask any of the team. And then I think you've all been made aware of our awareness campaign, the I Get Dilated campaign. This is something that you can help amplify some of these messages. And in this campaign, we have started to talk about the Vision Registry. So we've started to promote the Vision Research Project through a lot of these different avenues as well. The other day, we talked about our advocacy work and working with the FDA, the National Cancer Institute, to really help them understand the patient journey. And I think with the Vision Registry, it gives us even more power to have that patient voice up front. So we're talking with people at the FDA, with people at the National Eye Institute about vision data and how we can use the data from vision to advance the efforts of the FDA and the National Cancer Institute and the National Eye Institute. We actually have members of the NEI and the NCI on our steering committee, which has been great. And so you will see firsthand shortly labs that are doing research in ocular melanoma. And part of our research effort, as you heard the other day, is to fund peer-reviewed grants, which means that people apply for funding and that the proposals are read by expert researchers in the field, as well as patients and caregivers, and then are scored and funded based on that scoring system. So, and here are scientific meetings. We bring researchers and clinicians together, just like we're bringing you all together for an annual meeting in the fall. So through all of these efforts, we have interacted with a range of stakeholders. And you can see these stakeholders represented on the slide, and there are probably others that aren't even on here. And again, what we were hearing was that everybody's in their own little silos with their own information about patients and not able to access the broader information. And so we imagined a registry or a database that could actually connect all the different stakeholders. And what would be connecting them is you all, the patient voice at the center of that. And so as a community, really, we imagined Vision, virtual information system to improve outcomes and networks. And we pulled together about a 17-member steering committee. As Neil mentioned, he's now a member. And this was an interdisciplinary group of medical oncologists, social workers, nurses, patients, caregivers, epidemiologists, a very broad group who was advising us. And we spent about 5 or 6 years developing this registry. We wanted to develop it specifically for the ocular melanoma community. So there are a number of different platforms out there, and we looked at many, many, many of them. And we decided none of them were sort of fit for purpose for the ocular melanoma community. So we partnered with a technology platform that, number one, is very secure, and number two, allowed us the building blocks to build something specific and special to the ocular melanoma community, and something that's flexible and nimble, so that as we learn more or want to ask different questions, we can change things, we can iterate, we can be creative and innovative as the field needs us to really move things forward. So the goals or the aims that we set out to achieve early on are to record global cases, again, so that we don't have cases split up into different systems, but to record cases in one system, to advance our understanding of the disease, and to increase collaboration. So to really bring together all the stakeholders, because we know not one lab or one researcher or one company is going to cure this disease. So let's bring everybody together to cure it faster. And on the right, you'll see the landing page. We built the landing page as well, very, very specifically. And each one of those dots is a patient story of a patient who is participating in Vision, and they wanted to share their reason why. And so you can click on those on the website to read about those. They're probably due to be updated. So if any of you would like to volunteer to have if you're in Vision and want to volunteer to have your story told, let us know. So I think I'm going to hand it over to Neil to kind of walk us through the platform.
Yeah. Thank you, Sarah. So with the Vision Registry, when you first go to that landing page that Sarah mentioned and click to sign in or register, you'll see a informed consent. So one of the things is, as we're collecting data and using it for research purposes and other demographic type items there, it is providing that consent in that. So this is sort of that starting point. Over the next couple slides, you're going to see some changes that are taking place. With Vision Registry, as Sarah mentioned, it has taken quite a few years to get to the point where we are now in collecting that data in that regard. But as with any technology, and then we've seen it on websites that we frequent, to do shopping and things like that. If you went to Amazon years ago, it looks way different than it does now in that regard. So these are some of the updates that you'll be seeing as we go through these next slides, and it's based on feedback from patients and those that have been using the registry over the past few years. Also, on Friday, trying to remember what day it is right now, but on Friday when you registered, you received the packet, and there is a Vision Registry or Vision platform brochure that's in there that has information, the URL where you can go in that regard, and maybe for those that are online, we can drop the link in so that they can see it as well. Okay. The data that we're going to see is also every year there is a report that's out. It's a 44-page report with data and information from patients, some of the quotes of reasons why they answered the question as they did, and to provide some of that, some of that knowledge. And I was looking through it yesterday and also this morning, and some of the reasons why patients answered away. It was interesting to see some of those little tidbits of those excerpts of those quotes. So once you register, log in, first thing is that there is a monthly newsletter. So as you go through that, you're going to receive a newsletter that we just started sending out. I believe it was in November of last year. So it comes out once a month. And we all receive a lot of email of information, and I have found that this is like one that I actually stop and actually read it and look at it and go all the way through, just because there's a lot of great information out there about, you know, what the data is seeing and those types of things as well. So we were talking earlier this morning about different ways to get information. So Vision Registry also does provide that opportunity for that email distribution. But this is, Sarah showed this to me 20 minutes ago. So this was the first time that I've seen this new landing page, making it much more easier to click and to go through those items there. As we look at it, you can see there's your documents and forms in that regard, statistics, but also there's a discussion forum that's out there that is, part of the platform in a way for patients to continue those conversations that we've been having these 3 days. There's also links to other education and support resources through CureOM, the Melanoma Research Foundation. So you have that as another avenue to get to that information. And the Vision Registry is not intended to be sort of like a one-time, oh, I fill out the information, here's where I lived over the years. It's, something that is interactive to provide updates of quality of life and other, if you've moved or those types of things, or other findings that as you're working with your physicians and oncologists to provide that input. So as you come back into it, instead of trying to figure out where you need to click, the platform in this next release, this update will really sort of guide you so that it makes it easier to collect that information and to, help pull that together and use it in the reports and research. And also, we're starting to look into some journals that we can submit data to, or, opinion pieces and things like that about why the Vision Registry is beneficial to the ocular melanoma community. So there are.
Bye, honey. Oh, every time I speak.
Sorry, I'll move. Okay.
Thank you, Mary. So in the Vision Registry, as you go through, there's 11 surveys. You don't have to fill them out in one sitting in that regard, but there are some that, as I went through, they were, pretty straightforward in terms of putting that information out there, your personal profile and information, but, some of that family history, places that you've lived in the past, and trying to track some of those items. There have been clusters of ocular melanoma that have been, identified. I think most of us are familiar with the one in North Carolina in Huntersville, and then also the one in Auburn, at Auburn University, with a younger population of that. So, the more information that we're providing, it really helps identify, sort of those trends and, why ocular melanoma happens. Is there anything, over the past few days, it's sort of, hey, this sort, those types of questions where we really, want to know as patients and to try to understand. And through these surveys, as we look at some of the data here shortly, you'll see that, these are the sources of that information. I've mentioned the Vision Registry data report. You do not have to be, a member of the Vision Registry to review that. If you go to the homepage that's Sarah mentioned earlier with the map and the little where those stories are, you can get the PDF. It's a 44-page PDF, the 2023 data report out there. And towards the back of it, there is a group photo from the Tampa Symposium. So we want to make sure we get a group photo sometime today so we can all be included in that regard. And it sort of walks through the, the range of ages, gender, and then getting occupations and things like that. So based on those surveys that are being filled out. So I think, Sarah, these numbers are from 22, maybe?
These are a little earlier in the year, so we have over 500 patients in the
Okay.
registry now.
So there's over 500 patients in the registry now. It doesn't mean that all the surveys have been completed. There are some surveys that may not apply, like metastatic and those types of items as well. But it's continuing to grow and get that additional information. So here's where we start to get into some of the demographics that's out there. So we can sort of see the age range of diagnosed. I know that we do have various ages out there. I was in the 17%. I was 44 when I was diagnosed. So towards the younger end, but I'm not as young as I used to be in that regard. But and then also, what country does the patient live in? So as Sarah mentioned, we're partnering with other groups and getting the feedback from around the world. And we do have, I believe we have members in the steering committee from multiple countries as well. So not just QROM here in the US, but making this worldwide, collecting that data in that regard. But the majority of the information is from the United States. And as you may have looked around the room and sort of look at the demographics there, we sort of see the same population in this room.
Hopefully with the partnership efforts around the world, we'll see, the percentages in other countries increase in this next year's data report.
Yeah. So the type of the primary diagnoses, and when was that official diagnosis made? As we're, rolling this out, the trend would be to see more recent than in the past in that regard, just, sort of the outreach and those types of items there. So this, will be interesting over the years as we continue to collect this data, as we also collect data, as we make contact with patients that are 10, 20, 30 years since ocular melanoma was diagnosed, getting their information and sort of seeing how this progresses. Financial considerations. So always, a question out there. And so this is where, I mentioned some of the excerpts and those types of things. So they're all in the report. I think there's even maybe some more in that regard. But I found that some of the financial considerations were interesting. We were talking over breakfast about health insurance in that regard, and a consideration of, I used to be self-employed, and now, fortunately, I was fully employed with health insurance when I was diagnosed, because it would have made a huge difference in that regard. But for most, there were not any financial considerations that made it difficult in that regard. But some of the quotes here, insurance company rejects claims in that regard, and getting that information, because how could the MRF and QROM help in that regard, that education, that outreach, as part of those three pillars. And then sort of drilling down a little bit further in that regard. So this is a subset. So, based on the prior question. So of that smaller percentage, sort of drilling down in terms of that. So that's why we see the lower number of responses. So the number of doctors that one saw in order to obtain, that diagnosis, I'll say for myself, it was 3. The second doctor knew what it was, but, and I saw 3 doctors in one day in that regard. But, so, trying to understand. So for most of us, it really was going to one doctor, something doesn't seem right, and, getting that information, but, really trying to identify, how many physicians it took, because, once again, over this weekend, we've had the conversations of, oh, you can't have ocular melanoma unless you've had cutaneous, was one myth that was out there. And I've talked to doctors as well that were providing me incorrect information, but just like people I met, like in Tahoe at a blackjack table. I gave that example earlier, where he was convinced he was right, and I was happy he was losing his hands. And then, once again, collecting the information and, getting an idea of, what were those symptoms? We all had different symptoms. There was blurred vision, as we've been chatting, and other items there, flashes, some may have had in that regard. But really trying to understand where it's coming from. And, being in IT, but just being a more so technical type person, I can really geek out at all these numbers and information, because it, really is interesting to get that information and, build the base of information that we're providing to the researchers, to the clinicians, to the physicians, so that they understand our journey as well. And then also traveling. I know I'm quite fortunate. I guess I can say that I have a physician that's under 10 miles from me. When I was initially diagnosed, had no idea, and I ended up walking home from the doctor's appointment over 5 miles. So, but also, what is that distance that's out there? And, we can see that a lot of the individuals that have responded, it's, within, under 100 miles in that regard, but we know that that's not always the case. And so where does, sort of doing advocacy work on telehealth and those types of items and that outreach to better serve the population, so that we're not traveling across the country, or if we're in South Dakota, having to travel hundreds of miles to see a physician. So did the patient have a biopsy in terms of that? And, and what were those results? How did that change the treatment? So it's interesting that, 62% did, but also is it, when they were diagnosed, how, really digging in, can we find, how that information? So remember, the data that we're showing here is just a summary of what was in that 2023 report that's out there, but there's a lot, more digging that can be done to provide that information insight to the researchers. And then just sort of digging a little deeper in that regard. I'm not going to get into all the details of what we're showing, but, really highlighting some of it. But once again, it is all in that 44-page document. So patient priorities. At the time of primary diagnosis, what was the most important? So on the left-hand side is our patients selecting one item. Okay. So in the blue boxes, that will add up to 100%. On the green side, it's the percent of patients ranking first, second, or third in that regard. So this one, I was, as I mentioned earlier about the insurance coverage side of things, in terms of that, I was a little surprised that it was so low, because I think when I did it, it was definitely in the top 3. in that regard, but, you know, of course, it's all about long-term survival. You know, that's what we want to know. We want to, you know, be here 20, 30, 40 years out in that regard. But, you know, trying to identify what's important to the patient community that's out there. And, you know, so CureOM, MRF, you know, can focus on it, but also the physicians and researchers know as well. And then the surveillance side of things. So for metastatic, it is as I mentioned earlier, you know, not all the surveys would apply in that regard, but so with the metastatic, it is a lower percentage that is filling this out. So of the 123 patients of the data that we're looking at, only 20 had reported metastases in that regards, but it's, you know, starting to build a trend in that regard. And also as the type of treatments change based on the research that's being done, we'll see, you know, maybe some of the answers on the right-hand side will change as well based on different drugs and different directions that are being found. So the quality of life is actually, so there's, as I mentioned, there's a lot of questions out there, the socio, trying to get that initial information in that regard. But the quality of life is actually part of the, is based on the FACT-G, which is the Functional Assessment of Cancer Therapy General. And there's 27 questions that are sort of sprinkled throughout. And as I mentioned, the guiding of sort of when you come back, like the surveys, you know, these are some of the questions that, you know, as it progresses, you know, really trying to get some of those updates. So the numbers that you're seeing here, it's on a range of 0 to 108 is sort of the scoring based on those 27 questions. And it's, you know, a health-related quality of life. So, you know, really trying to get an idea of where that falls into. So why it's 108, I don't know. Maybe someone else does. But just to sort of understand the range of the numbers that are here. So I'll just put these up here so you can sort of take a look and, but you know, how it varies based on country and those types of things, or gender in that regard. For Canada, you know, it is showing a higher, but that's only one response in that regard, but it's, you know, getting through all the surveys that are out there. So it is important to do it, to go through those surveys. But as I mentioned, you don't have to do it in one sit, you know, at one time you can, or you can sort of do it over the course of days or weeks. It's, you know, what works best. So what are some opportunities for growth based on this, you know, in terms of the vision platform? So one is that quality improvement. So as I mentioned earlier, Sarah mentioned, you know, we're in the process of providing updates, and it's based on patients, you know, providing that feedback of, you know, and it was a little confusing doing this and trying to make those updates, but also, you know, as we continue to move forward, you know, are there other questions that would be helpful for researchers, for us, and others to help, you know, include that data as they're looking for grants and other items out there. Improve recruitment and retention. So that is, you know, coming back and doing the updates to it and sort of that guiding of it. One thing that is, I think, is ready to roll out with this next release is the integration to clinical trials. So sort of having it so that you can see the clinical trials that are out there. I know that we are all excited about the melatonin possibility out there that Dr. Sullivan talked about. You know, we've had a busy weekend, but you know, we probably won't have any problem sleeping the next couple of days, but you know, but as we recoup, you know, you never know in that regard. And connecting patients to those trials, but also connecting patients to each other. So there is a sort of outside the study area, there is another section that's, you know, going to be a forum where we can communicate, ask questions. Hey, well, we're going to, you know, we're going to see you in Cleveland in April of next year in those regards. And, you know, continuing those conversations that we've been having, not only here, but through the other support that Cure OM MRF provides, the Zoom calls and those types of things as well. And also connecting the patients to the clinicians and researchers. You know, it's not, you know, we're just patients, but we work together with that to provide that information so that they can more easily, you know, have that information available to help do their, to do the research. And as I mentioned, this is the new look of the discussion forum. I'm sure the Monday test will not be out there. And once again, this was something that Sarah just showed me, you know, right before this in that regard. So, so once again, for those of us here that were able to be at dinner, we got to see our aspiring talk show host ask questions, and there Sarah and Gigi patching for daddy. But you know, it's really, you know, building that vision of the future of Cure OM, and you know, knowing that we're not alone, you know, and working together, you know, patients, researchers, and clinicians, and you know, gathering that data so that we can help, you know, all forward to, you know, do that research for those different types of treatments, and you know, and what, you know, breakthroughs that can be found in the future. Want to talk about partnerships?
Yeah, just in closing, and I think Neil touched on this, we are working, you know, broadly with groups around the world to try and increase the number of patients participating from other countries. Right now, Vision is only in English, but we do have the capability to translate into other languages. But right now, we're working very closely with groups in Australia, Canada, the UK, starting to work in other areas in Europe as well to recruit patients, and also working closely with Omni, which is a clinical registry led by Rich Carvajal as the main PI and others. And so we actually consent patients in our consent to share data, and they consent in patients with their consent form to share data with us so that we can integrate the clinician data with the patient-reported data to really kind of increase the strength there. And just one other quick question, maybe I'll mention, you saw a lot of numbers of like an N of one, like one response from Canada and one response from Mexico. And we didn't put those up there, you know, thinking that like those are data we're going to hang our hat on based on one patient, but more just to give you a sense of some of what we, you know, can do, or the potential and the power within the registry. And we have so much data in the registry that what we have in the report is just a very small percentage of the data that we're collecting, and what we've presented here today is very small. And so we're really eager to work with industry and researchers who are doing clinical trials so that you know, we can take the patient-reported data and really increase and speed up research. So to really think about these data as sometimes standing alone, but I think the power of these data is really the integration of the data with other efforts. And so that's our hope. And so I think ending on this slide of partnerships is kind of on point. So yeah, thank you, Neil, and I'm happy to take questions. And certainly after the presentation, if you have individual questions about your own experience in vision or how to get involved, or if you've had trouble or whatever, come up to us after the fact too. But if there are any questions relevant to the group, well, yeah, I don't know if we have a microphone for people online to hear, or I can just repeat the question. Yeah.
No, I just had a thought as we're going through this. Well, a couple of things, a thought and a question. First of all, are you working directly with the physicians that treat ocular melanoma patients to then, we could sign a consent once we check in? Yes, we would like our data in vision, period. Is that something that A is already in the works? Or because we're all now signing in, and the minute we get into any office, we generally sign in through a kiosk. So it could be a matter of, 2 questions. Yes, I consent to my data. What is it being used for? Can it be that simple?
Yes and no.
Okay.
I think that's a great question and very on point. So the data that we're collecting is patient reported. So it's not going to be in your electronic medical record, how many doctors you saw to get your diagnosis, how far you had to travel. You might be coming to Dana-Farber as your main, place of treatment, but you might get a second opinion in New York, a third opinion in LA. And so each one of those centers, when you check in, that's not going to be able to provide those data. So the patient reported data, we actually need you to enter this.
That
But
brings
your
up my second question.
Yes.
Because then if many of us are in some sort of forum already, either virtual Zoom or some type of support group, if it could be either tacked on to the end of the support group, I allot an hour and a half to be on that group. So
Yeah.
the last 20 minutes, before you click out of Zoom, click here and do your 5-question survey for what your experience has been in the past 3 months. And, as simplified as we could do those questions. How many doctors did you see? How far away were they? Are you changing medication? Whatever
Yep.
pertinent data you want to.
Ryan's
That
taking
would
notes,
be
and
simple.
that will be implemented next week. That's a great suggestion. So that's a great suggestion, but I just to say that also your first point is not, it's a very important question. And I think for the Omni study that is pulling data from the electronic medical records, I think that they're always looking for ways to streamline that and also to integrate these two. And so I think technology hasn't quite caught up to this type of research to do this as effectively as possible, but we're always talking with folks who are innovating in this space, and the more streamlined this can be for you, the better it is for everybody. And so these new images that Neil showed you, this is based on patient feedback where we've tried to streamline the patient experience. So we're trying to get closer to what you're saying. We're not quite there yet because the technology isn't quite there yet. But I'm hoping we will get there. And as you all engage with vision and have suggestions like this, please do reach out. And Jackie Kraska is our data and research manager and couldn't be here this weekend, but she's very accessible and always taking this kind of input. And it's this kind of input that led us to these changes that will roll out live in the next month. So really appreciate all of your questions and comments.
I think I might have I think I might have filled this out, but I don't know if I did, and I don't want to fill it out twice and skew the data. Is there a way to check to see?
Yeah.
Just did that.
Oh,
You just skewed it? I put in my email and forgot passwords and all back to me. So if you've done it
Okay.
once, yeah.
And if that doesn't work, so sorry for the people online, the question was that if you think you put your information in, but you're not sure, you can either put your username in and it'll send you the prompt for your password, or if not, you can email J Kraska and we can give this to you at melanoma.org and she can check.
thanks.
She can help you with that.
Will there be intervals where we'll have a follow-up questionnaire? Because I'm thinking, as we were going through this, I think there's things I would have answered that I would answer quite differently now compared to when you rolled it out. What was it, 3 years, 2.5 years ago?
Yep. 2.5
I
years
did
ago.
it right away when it rolled out, but I think my quality of life has gone up tremendously since I left my job and retired.
That's got nothing to do.
So
with
Good to know for those of us not retired yet that there's. So the question is there an opportunity to update? So yes, and in this new iteration, what we're hoping is patients will actually go in every 3 to 6 months, and we have prompts that you'll get via text, via email. Maybe Neil is gonna bring it up. And basically, we're gonna ask you to go in every 3 to 6 months and fill out the quality of life. The FACT-G, we're using it a little differently than it was validated as, so but we'll ask you to go in every 3 to 6 months, fill out your quality of life survey, and then we'll prompt you to update any other medical or sociodemographic information that may have changed. And so these are some of the new prompts that will be launched with this new iteration. So yeah, appreciate that question. So we're trying to put guardrails, because I think up until now, patients go in and trying to figure out, where do I go? What do I input my data? And based on patient feedback, we've tried to put these guardrails to, you go in and we tell you like where to go to make it easier.
First of all, I just want to say, very impressed, and I know nothing about really databases and applications, but it seems as if a massive amount of work has gone into this to kind of think it through so that you can end up with a meaningful result at the end. And I guess my question is somewhat similar. I just asked Mary if she had signed up for this, and her response was, I think I signed up for it, but haven't done any surveys. And I'm sure part of that's new, but I guess what I want to say is, I think it's okay to guilt the patients into wanting to participate. And I mean that half jokingly, half seriously, but it's not like we get a survey from our bank, that wants to ask, how to provide better services. Everybody who you're sending the survey to is vested in wanting to get this information, to get it, succinctly, so that the information can be distilled and used by the patients as well as the medical community. So if there's any reluctance on the part of the individuals who are concerned about pushing the patients, I would just put that aside and I would just push.
So you met our niece. Why don't we'll have you do a testimonial with our niece that she can post on social media, and you can guilt them from your mouth to the patient community. That's great. Our niece is right behind you. You can meet her after the. No, that's great. And I think as we're integrating the registry into efforts, like into clinical trials, as hopefully more clinicians are handing this brochure to patients in the clinic, as we're working with more industry partners, we're starting to work with industry partners where they are integrating vision data, or we are adding a survey for them into vision. There will be more avenues to come in as well. And so it won't just be us with a megaphone saying, hey, patients, sign up, but there will be other avenues that patients will be coming in. And I think that will be helpful too. But I think people have heard your message and will hopefully do a better job of guilting patients here and there too. Oh.
So one of the items that I brought to this, I've mentioned to Sarah and Jackie is on that monthly email that comes from the Vision platform to say, have a reminder on there, hey, have you updated, and trying to do that, and, hammering it through the email, because it's the nagging that's gonna do it. And, and maybe we can even say, hey, we had X number of people, sign up, have you, and, go into that, because I don't think any of us in this room are against guilting others to do it, so.
All right, maybe one last question. Yeah.
So initially said that there are around 500 kind of patients. What do you think is the penetration rate we have so far? How far is the gap, in general sense? Okay, you are almost 20% of all the patients covered in the system. So okay, what is the goal, for this system?
Yeah, that's a great question. So we had a lot of, and I would welcome other people chiming in here. I mean, when we were building the registry, we had a lot of these conversations about what statistically, what number of patients did we want, but also just like feasibility, how many could we expect? So if there are maybe 2,000 patients in the US diagnosed each year, maybe 5,000 globally or something like that, we sort of estimated just cost-wise that maybe we could get 20% of newly diagnosed patients to register each year. We're not there. And as you saw from what Neil presented, you know, I mean, ideally, we could be capturing patients when they're diagnosed, because right now we're getting patients after they're diagnosed. And so patients are sort of having to think back to what happened at different visits or whatever. But really, I think ideally for patients and for the data that we're collecting, it would be prospective. So patients would register when they're diagnosed and then fill in the information in real time, and we'd be capturing quality of life in real time, et cetera. So what we're getting, I think, is not sort of ideal data, but it's the patient voice. So we are definitely, you know, making the best out of what we're capturing. But I think we sort of budgeted and hoped that we would catch 20% of the newly diagnosed patients eventually, once we sort of got moving slowly. I don't know if, yeah. So we're not there yet. But really, really great questions.
So I've got one more, and it may
Sure.
be completely meaningless, but at the outset, you said you looked at a whole bunch of existing platforms and they didn't work because you had some unique needs that weren't being fulfilled, so you had to go out and build your own. What was different about uveal melanoma that other platforms weren't working that must work for other diseases?
Yeah, that's a great question. And without taking the entire next hour explaining, because we spent about a year doing this research, but it's a really great question. I think it was a variety of things. I mean, first and foremost, it was ownership of data. So there are a number of platforms out there where they'll partner with different groups, but then they own the data. And we thought it was very important for the ocular melanoma community to own our own data and to be able to control what we do with it. So that was number one. Security, different systems have different levels of security. The questions that are asked, different platforms have different opportunities to modify the questions. So some platforms, you know, you had to just use full surveys and you could pick or choose surveys, but you couldn't edit within the survey. And not all of those questions were applicable to the OM community. A lot of them, we knew that if we wanted to change things, we were sort of at the mercy of that larger platform. So let's say they serve, you know, 10 or 20 diseases. Well, they were going to decide when to edit the system and the questions. We couldn't have that control. And then I think the nimbleness, like it took us, you know, I think it took us longer than had we pulled one off the shelf, but now we're actually working with industry partners who say, look, we have a clinical trial. We want to use vision to help us advance this faster, and we can be nimble and flexible, and we can build a new survey, run it by our IRB, our ethics oversight, and we can implement it within the next month or year or whatever the time frame is to develop it. And we thought that it was important for the ocular melanoma community and all of those stakeholders to have that kind of control and influence. Ultimately, we felt that this was going to help us advance the field faster, even if it took us a little more time at the outset to set it up.
Thank you. You distilled a year's worth of work.
Well, thank you all so much for your, oh yeah.
So, you know, as we've gone through this, if we could just ask for 2 takeaways. In the first, some of you already have been doing, saying, hey, have I registered yet? And seeing, and if not, you know, taking a look at the vision registry and, you know, and take some time to do the surveys. And the second would be, you know, as you get back home, you know, next time you see your physician or, you know, see if they're aware of the vision platform and, you know, because it's not just, you know, the 2 of us up here talking, you know, we're a community, and the, you know, the quickest way to build up the amount of data is to have those conversations. Liz, you had a great idea about the support group and mentioning it there, and Ryan's back there shaking her head. So thank you in terms of that, but just, you know, continuing to have that conversation, you know, with those that we know with ocular melanoma that didn't have the chance to be here this weekend in that regard. So I would just ask for those 2 items. Thank you.
Thank you, Neil. And I think we're going to hear, you know, research from a number of different perspectives this morning. And I just want to thank Neil and all of you, because I think all of the research you're going to hear about this morning is really, you know, patient-centric, and with the patient really at the center. I think vision, we're co-principal investigators with all of you. So like this project is a really grassroots project, and we can't do it without you. So I really want to thank Neil and all of you for being such amazing leaders in this space and co-conspirators. It's what it's going to take to move this forward. So thank you, Neil. And now we'll transition to, I think, some different perspectives on research. I think this is an exciting morning to hear sort of this wide range along the continuum of research. And I think that the next one we sort of talked about, I think, is it fair to say translational research, Dr. Sullivan? And we'll hear some more about that sort of bridging clinical research with kind of a more molecular or perspective in the lab. And then we'll hear from Dr. Hawk at the end, with a really more basic science approach, and then go see some of those basic science approaches in the lab. So I think most of you were here on Friday when we heard from Dr. Sullivan, and maybe some of you actually raced against Dr. Sullivan yesterday at the event. And I don't know if Dr. Sullivan won yesterday or not. Okay, he'll give us an update, but I have to say, regardless of whether he won yesterday or not, he wins every day for ocular melanoma patients in both his research and clinical work. So as you all know, Dr. Sullivan is a medical oncologist at Massachusetts General Cancer Center. And thank you for being back with us for day number 3.
Okay.
Let's see if I can get rid of this notification right here. I don't know. Okay, hold on 1 second. It's not serious, right?
Yeah. I got through.
We should be good to go.
Right, thank you. So it is a pleasure to be here and spend Sunday morning with you. So the update from yesterday, I did not win. In fact, if anybody went yesterday, there was 3 laps that you did. As I was coming around the bend to finish my 2nd lap, the winner ran so fast past me, so fast. It was like he was on one of those scooters. And he finished, and I ran across the finish line, which of course wasn't my finish line because I had one more lap to do. And I said, please check him for steroids. And he looked at me like disgusted, like, what's wrong with this guy? No, dude just lapped me. In fairness, it wasn't that hard to lap me, but actually it was hard to lap me because that guy was running really fast, but it was impressive. And I was running with one of my colleagues' sons, and when he ran past us, like, you want to catch him? And he's like, no, he's running too fast. And I said, no, and a bad idea. Okay, so that was the update on the race. So no, I did not win. In fairness, I wasn't expecting to win. So just a bunch of talk, and I was trying to hype myself up in the race up yesterday. Two actual thoughts before I get started. One, I will say this about the uveal melanoma community. My patients with uveal melanoma are so much better educated than my patients with any other type of melanoma. And it's not that they went to more school or have secondary degrees or things like that. It's that the community is really invested in educating each other. And I think that's amazing. And so I'm
pleased to be here to help with that, but I'm really grateful that this community exists to provide support. And that's directly related to efforts by Sarah and by CARE-OM and by MRF, but also by you all. And so I'm grateful for that. The second thing is I think Neil's is a cautionary tale. If you have a lot of recommendations and you go to the boss and you say, hey, I want you to do this, this, and this, you've automatically volunteered yourself for something. So just throwing it out there. It's true for volunteer work. It's also true for real work, like when you're actually at your job. So don't tell the boss all the things you want to do, because then you volunteered yourself to be on the committee. So the title is Potential for Circulating Biomarkers in Uveal Melanoma. So let's talk about what circulating means. So a biomarker, really quite simply, is just anything that's biologic or pseudobiologic that may help understand something about a disease or a person with a disease. When we tend to think about biomarkers for cancer, we often think about tissue biomarkers, which are those that are sort of basically analysis on tissue samples, or blood-based biomarkers. And so I figured I'd just go through some of the advantages of each of those. So blood, obviously, nobody really enjoys having a needle stuck in their arm, but by and large, blood draws are pretty safe. And for most, it's pretty easy to have a blood draw done. And you can do it repeatedly. So serial sampling is much easier than it is for a tumor. Interestingly, if you biopsy a tumor, you're really just biopsying one part of one tumor. And so if it's the only tumor in your body, it's going to be more representative of all the tumors in your body. But if it's one of multiple tumors in your body, it's not necessarily reflective. Whereas the blood and whatever you're measuring in the blood may actually be more reflective of the entire disease burden or the state of how your body is interacting with cancer. And then the other thing is that as we're continuing to develop new tests and with all kinds of fun bells and whistles to those machines, blood should be pretty straightforward to be able to be sampled and assayed using any new platform that gets developed. And then in addition, there's ready access to normal samples for comparative analysis, meaning it's really not that difficult to find either people in the lab that are willing to put their arm out because you're paying them, or more importantly, databases of people who have donated blood or having blood drawn for other reasons, and they signed the consent form that you mentioned there when they went to have their blood drawn, and so now they're having, you can find hundreds, thousands, tens of thousands of samples that can be tested to compare if you develop something that you think can be useful for patients. That's a blood test. The advantages of tissue is it's the gold standard. The sample is obviously enriched for tumor because you've stuck the needle into a tumor. And as opposed to blood, which has other shed elements competing for the tumor signal, right? Like there's a lot of things in blood that have nothing to do with tumor. So that's useful, and it's more amenable still to sequencing but more and more we're able to do sequencing on blood. And the tumor microenvironment, which is literally the actual way that the body is attacking the tumor or the tumor is establishing a network that supports it. The literal tumor microenvironment is in the biopsy, whereas anything you're trying to sort of inform yourself about the tumor microenvironment from the blood is obviously by definition indirect. Okay, so circulating factors do likely represent what's happening in tissue, and so on here, see my little, yep. So I'm not sure this is to scale. But the bottom line is there's a lot of things in blood, and The picture shows it. This is maybe the greatest thing I did in like 2013 or 14, whatever year I came up with this. Doesn't it look like, Riz? Like, it's not bad, right? Like, that looks like the stuff that you might see in the lab. So there's different parts of blood. So there's serum or plasma, depending on what tube is used to draw it. One thing can be serum, one thing can be plasma. If you ask me to define the differences between serum and plasma, I'm gonna point to Riz and ask him, and he probably will come up with a much more beautiful explanation, but I still don't understand the difference. But in serum and plasma, there are proteins, there are little substances called exosomes, which are encapsulated parts of cells, and they're circulating free DNA. In that whiter thing under between the yellow and the maroon is called the buffy coat. That's actually where the blood cells, so the peripheral blood lymphocytes are, other immune cells. If they're circulating tumor cells, they'll be there. The platelets tend to land there. And then the red stuff are the red blood cells. And you might be able to learn something from analysis of any and all of those things about what's happening in a patient for sure, but also what's happening as that patient has cancer and how their body's interacting with the cancer. So just a quick definition: circulating tumor DNA, which again comes out of that plasma/serum part, is all circulating DNA. Is called circulating free DNA, meaning anything, if you take the plasma and you can isolate the DNA, that's circulating free DNA. Some of it is not tumor. And if somebody has cancer and that cancer is shedding DNA into the blood, some of it will be from tumor. The tumor DNA we called ctDNA, or circulating tumor DNA. And the way it's usually quantified is that you put this thing called the allelic fraction, which is essentially a percentage of the circulating tumor DNA over the circulating free DNA. And so I'll show you a few examples, but often the circulating fraction that can be measured is like 1% or a little less than 1%. So you have to have, that's actually a fair amount of tumor DNA that's in the blood. And almost most patients who are diagnosed with cancer, but you can't see it on a scan, or they've just had surgery, you won't be able to detect it. And then varying percentages across varying diseases, and depends on where the tumor is, where it's shedding, and is it shedding, will have different percentages of positivity. So patients with colon cancer that have metastatic disease in their liver, almost all of them, you can detect circulating tumor DNA. In a clinical trial that we did with the drug tebentafusp that led to the approval, 60% of patients, 62% of patients had circulating tumor DNA that was detectable. So it does vary. Actually, in the study right before that study with tebentafusp, it was like 83%, because those were patients that had multiple rounds of treatment and then were able to get tebentafusp, and so their disease is worse, just kind of as a group compared to the patients that had never been treated before. So it really does depend on where in the disease course a person is as to how likely they are to have tumor DNA in their blood. I showed this in 2 slides before, but this is tebentafusp is this drug that got FDA approved that I think everybody in here knows about by now. As part of the study, we looked at, can we treat beyond progression? And it looks like we can. And as I said, about most patients, so 62% of patients had circulating tumor DNA. And amazingly, the drug itself, despite the fact that we don't see major response rates in more than 7 or 8% of patients, but almost 40% of patients who had circulating tumor DNA at baseline that was positive, it went away at week 9. Now, why did we check week 9? Well, a bunch of time points were checked. So patients were having blood drawn throughout this, but the 9-week time point was like where the best data was and where the most patients that we had samples from. So we don't actually know that week 9 is the right time to check. But we know using this test that 40%, almost 40% of patients had complete clearance by week 9. These are of the 62% of patients that had circulating tumor DNA. I showed this as well, but those patients who cleared had way better outcomes than the patients who didn't clear. And so higher is better. There's something to this, whether it should be rolled out and used or not, without more work being done. It's possible, but there's something to this that at the very least, you can tell a patient who's has circulating tumor DNA that's positive and then it's negative a few months into treatment that you're likely to do better than you would have if it hadn't cleared. Now, how can we use a test like this? Well, one thing we could consider is that we can start a drug and do analysis at baseline, do analysis on treatment, and then essentially you're sort of pulling apart what would be called the responsive patients, even though it may not be responsive from a scan, but responsive by a test. And so if we're saying, well, let's just call it 50% reduced or cleared versus not. And so in the patients who fall into that category, maybe you just continue treatment. And in the patients that don't fall into that category, maybe you say, well, it's time to escalate therapy, either add something to it, although we don't really know what to add to TEBI, or to switch to something else. Particularly if you're seeing evidence of imaging that suggests that the tumor is growing, maybe that's the scenario where treating beyond progression isn't the appropriate thing, and that you should really be thinking about treating that person with something else. So as I had mentioned on Friday, that test was just looking at hotspot mutations. These are mutations that are commonly seen in patients with uveal melanoma. They go by names like GNAQ and GNA11 mutations. You look at the very specific parts of those genes that are commonly mutated. There's really only 2 spots in each of those genes that are regularly mutated. And then also looking at about 3 other genes. So this is a shout out to all those Gen Xers or older millennials. If you sing the song Jeremy, the Natera's bespoken comes logically that actually works in the song. Try it later. If you disagree with me, you can tell me. I'll be okay. So this is a patient using Natera as a company that I have no idea why there's gibberish here, but Natera is a company that does a test where you send tumor, and from the tumor they isolate the DNA. They look at the mutations. They figure out what are the most likely mutations that would be continued in the blood, and then they develop a test that has 15 different mutations, up to 15. And then they actually do mutations per milliliter. So it's not this percent, it's actually a slightly different endpoint. But in any event, higher is worse, 0 is best. The numbers didn't come out, but that's okay because you can sort of see what happens. So this is a patient, I don't know what happened. This is 3 weeks in, we did a blood draw, it was really high. And again, the data that we have is from 9 weeks. So I just said, I don't know what that means. Maybe the tebentafusp is actually doing something and there's killing cancer cells and there's more cancer cell shedding of DNA, whatever. In any event, but the patient's subsequent tests continued to go up. The patient had 1 tumor that was growing. And so we actually blasted that tumor with cryoablation, which is basically sticking a very cold probe into a tumor. And then the test went down. And so it's remained down. It was a little itty bitty blip most recently. But so this is an example of where I think using this is helpful. You see something growing, you know, well, maybe that's just tebentafusp, maybe it just takes some time to work, but consistently things were going up. We treated that tumor and the tumor DNA got better. This is a patient also started to bentifusc and had some slight growth on exam. Actually, her first scan, which is around here, looked worse. Second scan looks stable. Third scan looks stable. Fourth scan looks stable. And so the level continued to go up and now may be leveling off. And the tumors on scans look okay, so I haven't felt compelled to do anything different. So this is an example where maybe following circulating tumor DNA is more confusing than anything else. But I think as we get more and more experience doing this, it may help us to understand when these types of things are more useful or less useful. This is an interesting story of a woman who's on a different type of drug. This is a phase 1 study of a drug, and she started on this dose because that was the highest dose at the time. Her tumor DNA was growing. Her tumors themselves were pretty stable. Some were getting a little bigger, some were getting a little smaller. And we were able to increase the dose as part of the clinical trial. And we did that. And you can see the circulating tumor DNA in the setting of increasing the dose got better, which is really cool. And this patient continues on this phase 1 trial. And the circulating tumor DNA continues to be flat. And actually there was an even subsequent increase to this dose now. So that's an example where, again, the scans don't really change a whole lot. Some things even look a little bit worse, but things in general in the blood look better. And so we've continued this patient on study. This is an example of using circulating tumor DNA to try and inform what we should do for patients. And then this is a woman who, at this point where the star is, started ipilimumab and nivolumab, and actually had a remarkably steep rise. So some of those other tests were like 1 or 2 or 5 or 6. This is 250, so suggesting a very high tumor burden. This woman went on darovasertib and had a remarkably steep reduction, but had some tolerability issues. And as she was having tolerability issues, the tumors started to grow, and you can actually see that in the blood. So this is a really pretty good way of tracking what's happening to patients. And when you see it in the context of these types of treatment stories, you begin to kind of understand the power of this, particularly in a disease where scans don't often reflect as well what's happening. So just a quick story, and then I'll end a little bit early so that you get to hear from Dr. Hawk before the tours. This is something called ultra low pass whole genome sequencing. So this is, you draw blood and you do genome sequencing. So there's exome sequencing where you're just looking at the sort of part of the DNA that's encoded for into RNA, but you can also do whole genome sequencing, which may be a bit more powerful. And you can, the way they cut this up is these are all the chromosomes. And so you can see, we talked the other day about monosomy 3. So here's sort of partial monosomy 3, because that's got less of the third chromosome. We talked about 8q gain. So this is where 8q sits. That's 8q gain. So you can actually look at the various parts. As I also mentioned on Friday, when you look at a lot of cancers, this is just gibberish. Things are going up and down. It means stuff. But it's in uveal melanoma, there are these very characteristic changes that we reproducibly see. And so this is a cool way of doing this. This is, so we sent like 17 or 18 patients worth of samples to the Broad Institute, and they did this analysis. And so this is a patient, and they calculated the tumor fraction. And again, the tumor fraction is basically the percent of tumor DNA over non-tumor DNA in the blood. So initially it was 0.06, so 6.7% or 6.6%. And then the patient went on a PD-1 inhibitor, and the number got worse, 37%. So this is an example of using a different way of looking at circulating tumor DNA, calculating a fraction, which is basically the percent of tumor DNA in the blood. And you can visually see it, like this is higher, kind of, but you can actually computationally calculate it. This is actually a patient of mine who, again, 8q, who ended up, when I met her, she had actually I met her, we did a few other things, put her on a clinical trial, sort of like the And then she got tumor embolization, and then she's about to start a trial which randomized patients to ipilimumab or nivolumab, and then at 12 weeks they switched. And then 12 weeks later, they could continue on nivolumab. And so she had a 50% of the DNA in her blood was tumor DNA at baseline. She had an amazing response. And on clinically, her amazing response, or like radiographically, her amazing response wasn't that amazing. It was good, like it shrunk, but she still had a lot of tumor on a scan. But in the blood, that went from 50% to 0%, which is incredible. And she remained on study drug for like 6 or 7 years. She did incredibly well. And you could, this doesn't take a rocket scientist to say that person probably did better than this person, right? And she did. And so we actually got really excited about looking at that 8Q gain in the data from our 16 patients. And so we recently published this collection of samples, but basically we worked with Takami Sato, who is a computational postdoc at the time, and he really got excited about coming up with a way to quantify this chromosomal change that's characteristic in patients with uveal melanoma. And so just focusing on 8Q, what you could see is that the 8Q score, if you had low 8Q score, those patients live longer. So this is like patients living 3 months compared to patients living like 3 years versus patients, sorry, it's the opposite way. These are patients who did poorly, who had high scores, and these are patients who did really well, who had low scores, but lived for a long time in their diagnosis. And when you compared it to tumor fraction, it looked like it was a little better. Like these are patients that had low tumor fraction, but did poorly. So we sort of, those folks were pushed up in this analysis using this very different approach to it. So we think that there are probably better ways than just looking at tumor fraction. And so our summary was that emerging data suggests that ctDNA monitoring may make decisions for uveal melanoma patients a little bit easier with tebentafusp, although that's mostly conjecture so far. There'll be more data presented in a few weeks at the American Society of Clinical Oncology. The optimal ctDNA platform is not clear. So whether it's bespoke or hotspot mutations or doing something different, like looking at this low-pass genome sequencing and looking for 8Q gain or other types of changes that may be more characteristic. But I think the major conclusion is that more work is necessary in sorting this out. So thank you for your attention. I'm happy to answer a few questions before this talk. Yes.
I am just wondering, I'm really at the beginning of my journey and have no meds at this time, but tomorrow may make it different. I am wondering, is this kind of material something that our clinician would share with us when talking about the results of our test or where to go? I mean, would we expect to see graphs or just you're doing well or you're not doing well?
I guess it depends on the doc. And I mean, most importantly, it depends on whether they send something like this. I'm not sure it's appropriate to send it in patients who don't have metastatic disease who are going on treatment.
Mm-hmm.
There's a lot of work in that space. There's a lot of work in the space of like people who don't have cancer. Can you detect changes that might be associated with cancer coming back earlier or being diagnosed with cancer? And then there's a lot of work going into trying to determine whether these types of approaches are useful for folks who have been diagnosed with a cancer. There's clearly a risk that that can come back. And maybe this is a way that could actually spare some scans. But I think right now we're not sure. And the caution I would say is that in that trial of tebentafusp, which was patients, everybody in that trial had metastatic disease, only 62% were positive using one of these tests. Now there may be better tests out there. So, but still, if you were just using that as a way to monitor, you'd be losing, you'd be missing a certain, significant percentage of people who ultimately develop metastatic disease. So I think there's more we need to know about it, and there's certainly a lot more to do before we start routinely testing patients who are at risk for cancer coming back with this approach, at least with this type of cancer. But it's certainly something that the field in general, not just those studying uveal melanoma, but studying cancer more broadly are looking at.
My hesitation comes from my biopsy results, which show that I'm at high risk, so,
Sure.
no.
Yeah, no, I get it. It would be, I think on some level, it would be amazing to have a blood test that we could utilize in your scenario that might help us feel more confident. That, oh no, it's negative. It's really good. You don't have to have scans this time. Like, that would be awesome. I think right now we're sort of stuck with routine imaging and
Thank you.
folks. That's, yeah, yes.
I see Dr. Richard Carvajal, and I get the ctDNA blood biopsy done every few months, and I was like fascinated by it. So I was doing some research on it recently, and I read an article, and I'm curious if your thoughts on this, that looked at circulating hybrid cell biopsies that looked like it might be more promising for, I guess, like being more accurate in terms of detecting, like,
I'm not sure what a circulating hybrid cell is.
Okay.
I know what circulating tumor cells are. And there's a lot of different ways of looking at circulating tumor cells. One of the major challenges with circulating tumor cells in melanoma is that most of the tests that are used to test circulating tumor cells use an antibody that binds to something that's expressed on most carcinomas. But it doesn't do so well at capturing melanomas. And so we've actually worked with our group at Mass General. There's a lot of effort in trying to capture circulating tumor cells. There's probably some utility of it, and we were actually hoping to roll out some of that in a clinical trial of a drug, but it's been slow in terms of getting patients to be able to be treated on that study, so we haven't really rolled it out. But I'd love to know more about what a hybrid cell is.
I could send you the article.
Sure, that'd be great. Yes.
So when you talk about biomarker directed escalation, you talked about how when treating with tebentafusp and you did a circulating tumor DNA analysis at the beginning and the end, and you split it in a group of responders and non-responders. And for the non-responders, you talk about escalation. What would escalation like consist of or be in that scenario?
Yeah, it's a great question. I mean, we certainly don't know what the best treatment post tebentafusp is. But the treatment that we typically would go to at that point, if we felt like the person was well enough to receive it, is either another clinical trial, or something like ipilimumab, nivolumab, which doesn't have a ton of benefit, and it has a lot of side effects associated with it, but probably 30 or 40% of patients get some benefit out of it, which is in that scenario after tebentafusp, probably the highest rate of clinical benefit after tebentafusp. So that's what we would typically do. And that is like an escalation. There's a lot more side effects that, and particularly as people go along in treatment, they tend to collect more side effects as opposed to tebentafusp. The longer you go along on treatment, the less side effects you have. Is that a question or a stretch?
No, that's a question.
Oh, okay. That's a weird way of raising your hand. I thought you were like stretching me.
This is what you were doing when the guy passed you.
I don't know. I was like, that's what I was doing. My mouth was agape.
So, so I was looking at the graphs, and so when the metastatic tumors, they leak more of the circulating tumor, that's why you were able to see it?
Yeah, it's a good question. So ultimately, there's more leakage in patients with metastatic tumors. It's probably less a leak and more an active process, but if tumor cells are dying, and sometimes what happens is you have tumor growth that outstrips blood supply, and then tumor cells die, and then that's probably true leakage of the material into the blood. Sometimes cells may actually be jettisoning DNA as an active process. When you don't have metastatic disease on a scan, but will develop metastatic disease, there's clearly a reservoir of cells somewhere in the body. And the reason that they're not growing and being identified on a scan could be that they're dormant. If they're dormant, they're probably not shedding DNA because they're dormant. Or they're being kind of actively controlled by immune elements in the body, in which case they're probably not shedding and they're certainly not large enough to be leaking the DNA in. So I think that's why it's some of it's stoichiometry. There's just way less cells, like billions less cells, that could potentially spill DNA into the blood. And then also the processes that sort of go into why you're not seeing the tumor cells, why they haven't grown yet. It may be less likely to shed the DNA.
Just one last question. So like when you start treating the tumor, does it like leak more because you're hurting it?
Maybe.
Maybe.
So that's why I was somewhat encouraged by my patient whose level went up at 3 weeks. But again, the way to test it is to do multiple testing, and then this is more my own therapy. So 2 years ago, we actually put together this amazing collection of patients who went on tebentafusp that we collected baseline 3 weeks, 6 weeks, 9 weeks, 12 weeks, 24 weeks. And we were sending it to a collaborator who had developed this commercial assay. The collaborator's in Switzerland, and we used a certain carrier to send it, and it ended up in Spain. And we never could utilize those samples. Yeah, thank you. It's actually like a collective sigh, because we would have learned something that we could have hopefully helped with the community, at least when's the optimal time to do that. So we have another set. We're using a different carrier and are hopeful that we'll be able to at least help answer when's the right timing to do that. Because I think it's too soon. You may get into that problem where you get a spike and it may end up being a good thing,
Yeah.
but you might be misled.
Right.
Too late may not matter if you're already doing scans anyway, so it may help you interpret the scans better. But my guess is somewhere between 3 and 9 weeks is probably the right time point to sort of get a time point that's far enough out that phenomenon of killing cells, leaking them, the DNA is past, but not so soon that you're just already going to have a scan that you're going to be potentially acting upon anyway. So
Thank you.
thanks.
So in the scenario in which the ctDNA goes up and the burden in the scans goes down, or the other way around, how does your process of decision-making about therapy look like?
Yeah, I think, so you sort of have to take, it's only one point of data. And so how the scan looks, how the patient's tolerating the treatment, how much disease is there. So patients with big bulky disease that I put on, and the scan looks worse and the ctDNA doesn't look that much worse, I'm still worried that I need to give them something different. I think it's really helpful when the scan's a little bit worse and the DNA is down, and I feel pretty confident to say, I don't love what I see on the scan, but I think the ctDNA is very reassuring, and it's okay to keep going. And that will scan you again in 8 weeks, but we're not going to go 12 weeks, but I think that the data supports continuing going. In that one scenario where the DNA continues to go up and the scans are pretty stable, I have no idea what that means. And so I just keep treating that person, because I'm not sure what it means to that scenario. It wasn't covered in our report of the tebentafusp phase 1 study or the phase 3 trial. But I don't know what it means. But in some ways, if we're being early adopters to this type of an approach, we'll begin to collect tens, 20s, hundreds of scenarios, and we may be able to make some sense of the data to more accurately answer your question, because that's the question. It's like, how do we use this data to help patients? And the answer is, I'm not sure yet. Some scenarios, I'm sure, other scenarios, I'm not so sure, but I'm pretty sure that it's still worth doing this, particularly if patients don't have to pay thousands of dollars for the test, which right now, thankfully, the companies have been pretty good at working with insurance, and when it's not covered, they usually will eat the cost. Okay, cool, thanks.
Thank you very much, Dr. Sullivan. Should we pull? Okay, we'll get the next. Sarah's going to help us get the next set of slides up here. And our last sort of formal talk of this morning is Dr. Rizwan Haq, who you all know well by now as well. And we're going to kind of transition to more basic science research. And this will kind of transition us to our lab tours after this. And then, as I mentioned, we won't be able to go as a group en masse to go through the lab. So we'll break off into smaller groups. And then if you're not on the lab tour, you'll be in here and we can have some more informal time for questions, additional questions at that time too. So thank you, Dr. Haq.
All right. So I have two tasks. One is to get you ready for the lab tour, which is going to be an experience of your life. No, seriously, I think it'd probably be nice to give a primer of what you're going to see, so that you can ask kind of questions now or during the tour. And then the last part of what I'm going to talk about is some stuff from my lab where actually the people who are actually doing some of this work, you will be giving your tours. It's stuff that I'm pretty excited by, and I think it has raised some somewhat provocative questions in my mind about this disease, and also led to questions about cancer in general, as you'll see. So normally we think about, we in the uveal melanoma community are learning from other cancer physicians, but I think in these cases, I'm going to show you where we've learned something in uveal melanoma that I think actually applies to many other cancers, and that's exciting. Okay, this is just to, I guess, reiterate what Ryan said. Thank you for being here in person, in line, this or online. This is such a great experience to meet all of you, and I'm also very grateful for the Science Sundays, Research Sundays, Science Sundays, because I think that, as everyone in this room knows, this is a disease that's going to be cured by research. And, emphasizing the importance of research, I think is something that must be stated and reiterated. And in fact, I think, in our center, we have a center of ocular melanoma, and our one of our goals is to accelerate this research across the Boston community, and that initiative is just underway now. Okay, so the first thing I'm going to tell you about is probably really, really basic to most of you, but I just want to make sure that everyone's on the same page in advance of the tour. So the basic unit that we work with in the lab is a cell. And this is sort of what a normal melanocyte, the precursor of melanomas, looks like. It has these kind of spindly projections, and then it eventually becomes a melanoma cell. And this process is called transformation. And this process of transformation is a extremely rare phenomenon. So every cell in your body, healthy or disease, has what we call nucleotides or letters, and there's 3.2 billion of them. a mutation that you've heard about many times is a change in one. So here's an example of the letters, a part of the letters in a normal melanocyte. There's an extra U that's inserted. That's a mutation, and that might be the GNAQ mutation that you guys have heard about. That's probably the instigator of half of uveal melanomas. So it's really subtle changes across a large number of data points. And this is why it makes it very hard to do some of the research that we're going to be talking about. Now, the other thing that you're going to probably hear in the lab tours is how we can manipulate these nucleotides, these letters. And why would we want to do that? Well, in every tumor cell, there's about 10,000 or 20,000 mutations. We don't know which of these are important. So sometimes we use tools, and you may have heard the tool of CRISPR, where we can essentially delete that one nucleotide, that one letter, and convert it back. And what that does is it allows us to ask, is this change, is this one mutation important in the survival of the uveal melanoma cells? We can also do the opposite. We can take a normal cell and using the same sort of genetic tools, convert this normal cell and create a mutation. And that again allows us to ask, does this mutation actually drive the uveal melanoma cells to grow? So you'll hear a lot about this in the lab tours. The other unit that we use a lot in the lab are cells. And I think most people know that we get melanoma cells from a biopsy. We take the biopsy, and through a process that usually involves several months, we can generate a cell line. And a cell line is basically a group of melanoma cells that are models of what we can expect in terms of drug response or responses to immunotherapy or their growth properties, et cetera. So for example, I think you'll see some of this in my lab. We can take a cell line, we can add drugs to it, and you can see as you increase the concentration of the drug, you have different colors which represent the number of cells that live. So we do this all the time in assessing whether a drug is going to be helpful for uveal melanoma. Unfortunately, not everything that we do can be modeled in cells. And this is where we do have to occasionally use mice. And you're not going to see mice, don't worry. But I will show you some examples of the experiments where we have used mice because the questions that we're asking just cannot be recapitulated in a petri dish. Okay, I really hesitated to put this slide in, but I keep on getting this question, so I'm gonna just go through it. What does this kind of research cost? So I'll just say it's extremely expensive. A single biopsy costs about $5,000. Making a cell line from that biopsy takes months. Sometimes it's not effective. And in case of uveal melanoma, the chances are that's not going to be successful. Creating one specific mutation, as we talked about, is over $10,000. And we can keep going, but this is extraordinarily expensive. And this is why we're grateful for all you do, all the MRF does to raise awareness and bring money into the research community so we can do some of these experiments. Okay, that's the primer. I'll stop there before I talk about stuff that I'm interested in. Yes?
The biopsy you're taking is from a metastatic melanoma cell? Okay.
So yeah, so the biopsy can be taken from anywhere. So as you heard from Dr. Wu and Dr. Kim, biopsies are sometimes taken the time of primary diagnosis. In the case of suspected metastatic disease, almost always a biopsy is taken at that point too. Okay. All right, so, oh, Sarah.
Just one question on the biopsy. In your lab, and the cell lines you're using are from metastatic samples or primary, and could you just speak to like what the difference may be choosing one versus the other? Just follow up on that question.
Yeah, that's a really great question. So we have cell lines from primary uveal melanoma, and we have cell lines from metastatic uveal melanoma. And I would just say that the field has suffered. Larissa's back over there has written a review on this. Hopefully it will be published soon. That sometimes the studies that are using primary or testing a drug that's intended to be used in patients who have metastatic disease use primary uveal melanoma cells. So the wrong cells. And this has led to a lot of confusion in the literature. And we know that the metastatic cells behave differently than the tumor cells. So you have to match the tumor type to the actual question that you're asking. Okay, so the three questions I'm going to get to are why don't existing immunotherapies work better for uveal melanoma? You heard a lot about ipi-nivo. We'll talk a little bit about that. Secondly, why does uveal melanoma preferentially metastasize to the liver? And then the third question, which came when we were studying question 2, was why does the risk of uveal melanoma persist so long after primary treatment? So just to kind of translate that, we know that there's a long latency between the primary diagnosis of uveal melanoma and metastasis, which is relatively unusual among cancers. There's cases of uveal melanoma where the treatment was the eye was treated with radiation or enucleation, and patients develop metastatic disease 40 years later. That's unusual, but it does happen, and it's extremely unusual among all cancer types, especially compared to skin melanoma, where that almost never happens. Okay, so this is a summary of an immunotherapy, which was used to treat several different kinds of melanoma. And what you can see is that some of the cutaneous melanoma, skin melanomas, around half of patients respond to that treatment. And this is uveal melanoma. Definitely some patients will respond, but it's significantly worse than those who have skin melanoma. Why? So the dogma has been for a long time that the reason for this is that the cancer cell, the uveal melanoma cell, needs to be recognized by an immune cell called a T cell. And that in uveal melanoma, there's lower numbers of these T cells that recognize and kill the cancer cell. And so we said, well, let's see, is that real? So we did a pilot study of 20 cases, 20 biopsies from patients with metastatic uveal melanoma and 7 with skin melanoma. And we quantified through sophisticated ways that I won't bore you right now, the type and the number of immune cells that were present in these tumors. And what we found was that, at least in this relatively small cohort, which we have later validated in a much larger group, is that the number of these key immune cells called CD8 positive T cells is actually a little higher than other cancer types. So this was not in keeping with the dogma. And there's actually some other papers that have suggested this. So the dogma was wrong. In at least in our view, these data would suggest there are immune cells in uveal melanoma metastasis. They just don't respond in the same way to the same drugs. And intuitively, this sort of makes sense. So this is a relatively old study, which was comparing uveal melanoma versus skin melanoma. And I won't take you through the figure, but if you just look at each one of these dots represents a different patient. And you wouldn't be able to tell between the skin melanomas and uveal melanomas in terms of, there's no clear lower number with the uveal melanomas compared to the skin melanomas. So the number is not that different. It's just the type of immune cells that are different. So what's different? So we said, well, let's take a much larger cohort of patients. Now we had 664 patients. 200 of them had liver metastasis. 464 had non-liver metastasis. And let's look at the type of immune cells that are present in each of these biopsies. And we did this through, again, a fancy approach where we could profile all 20,000 genes that are present in each of the cells. And the answer about what was different was seemingly nothing. So uveal melanomas in the liver are essentially identical to uveal metastasis from other cancer types. In other words, there was nothing unique about uveal melanoma. What was unique is that if you had liver metastasis from whatever type of cancer, those cells, the cells in the liver, were similar regardless of whether the cancer arose in the lung or the liver or the brain or et cetera. So again, the difference is that the liver metastasis in general have different immune cells than the other sites of metastasis. And there are data that actually show this clinically. So if you look at over 1,500 patients across all kinds of cancer, if you had liver metastasis, you had lower response to immunotherapy compared to those patients who had no liver metastasis. So we need to start thinking about the major issue with treating uveal melanoma patients that typically have liver metastasis is essentially a problem of liver metastasis versus non-liver metastasis. And again, I won't, in that whole complex diagram, I told you we studied this now for a number of years, and what we've identified are some key immune cells that distinguish liver metastasis from non-liver metastasis. And we think that targeting these particular immune cells could overcome resistance in liver metastasis, not only in uveal melanoma, but across all cancers where the cancer has spread to the liver. So this is an example of where we've taken what we've learned from uveal melanoma and now applied it to other much larger group of patients who have metastasis to liver. Okay, so now I'm going to just turn to this question: why do uveal melanomas spread to the liver? And I was asked to talk about this because we fortunately were able to get funding from QRM this past year to study this question. You would think that this is just an obvious question. Why do uveal melanomas spread to liver? And I will just say that it's the sort of striking preference of uveal melanoma to spread to liver is very atypical among cancers. Most cancers are skin melanomas, they spread wherever. Other kinds of cancer do have some preferences, but the very specific metastasis to the liver in uveal melanomas is pretty unusual among cancers. And that suggests that perhaps there's some sort of factors in the liver that allow those uveal melanoma cells to grow specifically in the liver. And if that was true, we might be able to intercept metastasis by blocking those pathways. So that was the goal of this work. Unfortunately, very little understanding we have very little understanding about why uveal melanoma metastasizes the liver. And I'd say part of the reason for that is that we don't have great models of uveal melanoma. So this is, we can't do this in petri dishes. There are very few mouse models that recapitulate this pattern where the uveal melanoma spreads to the liver. And that has made it very hard to sort of approach this question historically. So working with Bruce Sander at Mass Eye and Ear, we've been using a really novel model. So in this model, we initiate a primary uveal melanoma in the back of the eye. So we're adding roughly 5 microliters of tumor cells to the back of the eye. And you probably don't know what a 5 microliters is, but you'll see that in the lab today, and we'll test your ability on being able to measure out 5 microliters. And in this mouse, we follow them for 3.5 months, and then we evaluate what happens to these cells. And the cells are tagged with a color. Actually, it's green. And so we can see exactly where the metastasis happens. And so this is what happens after 3.5 months. So this is the liver, and each of these bumps are uveal melanoma metastases. So it's filled with metastasis. And I looked to see if we had a picture of a lung. We don't, because there isn't anything that you can see there. There's no metastasis, as far as we can tell, in the lung in this model. And so this model, to my knowledge, is one of the first models of uveal melanoma that resembles what we see in patients, creating the opportunity to ask the questions that we've been talking about, test drugs, and do some genetic experiments. So what can we do? Well, we can take a tumor cell, and remember there's 3.2 billion letters, nucleotides. Mutation is a change in one. We can use this tool called CRISPR, and we can systematically ask what happens when we mutate each important nucleotide. So what mutation introduced through this approach called CRISPR blocks the liver metastasis? And that was the sort of the basis of the grant that we received, and hopefully in a year or two, we'll be able to tell you. But what it allows you hopefully to do is find a target, find a way that we can block liver metastasis, not genetically, but with the genetic information, one can decide on which drugs can recapitulate that phenomenon and hopefully lead to an interception of metastasis. Okay, so coming back to this figure, because what I told you earlier was that if you looked at the lung by eye, there's nothing wrong with it. You didn't see metastasis. It's only in the liver that you saw metastasis. But that's not quite accurate, because if you start looking really deeply at the lung, you see something actually kind of amazing. So this is some pictures under a microscope of the lung and liver. And in red, these are the uveal melanoma cells. But when you look this is the liver, but when you look in the lung, you see these single or maybe double clusters of cells. And I want to remind you, we're looking at a mouse 3.5 months after the primary uveal melanoma cells were injected, which translating mouse to humans is about 10 years in human years. So 10 years after a mouse has an ocular melanoma in the eye, they have metastasis in the lung, which hasn't grown. It's there, just sits there. And so this is sort of, in my view, kind of a sort of crazy finding. And it's pretty provocative. And this has led us to a kind of series of hypotheses that we're testing right now. One of them is that metastasis occurs to the non-liver organs, but these mysteriously don't grow. And what that means is because these are single cells, they wouldn't be detected by CT scans or MRIs or any kind of clinical tests we have right now. And we think that these cells eventually can be reawoken from their dormancy through, again, pathways that we just don't really understand. And so there's one way to look at this and say, this is a really scary thing because, every person or many patients, if this model applies to patients, which we don't know for sure, any patient who had a primary uveal melanoma has dormant cells sitting in their body that we can't see because it's beyond the resolution of our CT scans and MRIs. And I agree, this is a scary thought. But there is a silver lining here. And the silver lining is that in most patients, these dormant cells are there for a very long time. So if they're there for 10 years, that gives us the opportunity to find an ability or find a way of targeting these so-called dormant cells and getting rid of them. And that's a focus of our work. So I will leave it that. You'll probably hear more about this in the lab. And I am sort of grateful to everyone who's in my lab. You'll meet some of them, and to the funding that we've received to do our work. And I'm thrilled to take any questions. Yeah.
So, I'll go back, the early slides, and you talked about the T cells. I mean, there's a lot more of those than you thought there. You thought it'd be the opposite, right? But basically,
Yeah,
But they're a different type of T cell?
No,
They're
it
different.
turns out to be a different kind of immune cell.
Immune cells, so
Yeah.
maybe I don't understand the difference between B cell and T cell.
Okay, so good question. So the immune system consists of multiple arms. There's T cells, there's B cells, there's macrophages.
Okay.
There's different categories of immune cells, and their function is to respond to cancer or infections and get rid of those.
Right.
We think that we've felt that the major contributor to the success of the immunotherapies that we have are by engaging these T cells. Because as you saw, if that was the complete story, then the immune system would be activated in uveal melanoma cells, and these drugs would work better. So what we find is that there's other kinds of immune cells that actually turn off the T cells.
Turn off it.
Yeah. And so the T cells are still involved, but they're just turned off by the presence of these other cells.
Saying that the cancer is a good cell, not a bad cell.
Yeah, it's hiding the,
So because there's so many of those immune cells, that means the immune system is recognizing, think these are bad, but then they're lied to until they're not bad. The T cells.
that's an interesting way of looking. Yeah, in some ways that's correct. I mean, the tumor cells are hidden from the immune cell. So in some sense, the immune system is not doing what it's supposed to do because it's supposed to get rid of these cells. Yeah.
I'm a little bit confused. Does uveal melanoma only metastasize to the liver? Or are there other metastases that you see?
Yeah. So I think that we are limited in answering that question based on what we can see by scans. So I think what we can see by scans is that the most common site of metastasis for uveal melanoma is the liver. And that is, I think there was a slide earlier that showed, I think it was in the vision talk, that 80 or 90% or maybe even more patients who have metastatic disease will that will be in the liver. I think that our data would suggest that in those patients who have scans that show no other sites of disease in their body, there are probably cancer cells there. And during a patient's journey with this disease, those cells in non-liver organs can reawaken.
Okay, thanks.
It seems like there's some great research in preventing possible metastasis. Is there any research for people that do have metastasis, and would the TIL be part of that arm, or is there something else that, is there any DNA sequencing to alter something of people that do have metastasis, see if it can be reversed or stop the progression of?
So I think just to make sure I understand your question is, can you modify the DNA of the cancer cells or the immune cells to block metastasis? Or
if metastasis has already occurred, is there any research to stop the progression of, and this just might be my misunderstanding of cancer as a whole, is there any research to stop the progression of it?
Yeah, so we are not yet largely capable of modifying the genetic material in your cells in people. We can do that in mice, we can do that in cells. There's some advances that maybe we can do that in some rare kinds of diseases. Usually we are relying on drugs. And the drugs could be drugs that block particular pathways, as we talked about on Friday, or harnessing the immune system. I think that, in my view, one of the reasons that we haven't made a lot of progress in developing those drugs is because we didn't have, or suitable drugs for uveal melanomas, but because we're doing all these experiments in plastic dishes. And I think the model, the mouse model that we now have, which recapitulates the disease, creates an opportunity to sort of kind of look at what are the most effective therapies for patients who have metastatic disease.
Something that strikes fear in my heart is brain metastasis, and it seems like somewhere along the way, I was reassured that that's primarily in cutaneous, but I'm just aware in the uveal melanoma world in our, groups, I'm aware of several patients that have developed brain metastasis, and I'm wondering if there's any research, any clinical trials coming down on if there's something specific to those people that do develop brain metastasis?
So I would say that the risk of metastasis to the brain for uveal melanoma patients is lower than, say, skin melanoma. There are some, I think Rich Carvajal had a paper last year that suggested that as the disease progresses, there is a higher risk of metastasis to other sites besides the liver and the lung and the brain as well. I think your question is about, are there research or clinical trials for those patients? Is that
Right, is there something specific to those people that develop brain metastasis? Is there thought to be something specific, or is it more of a secondary tumor burden and, from?
Yeah,
the
I'm not
brain
aware
or-
of anything specific, and I think the research has been very limited because we haven't really had great models to study it. We do have evidence from, say, skin melanoma that there are specific genes and pathways that are being turned on in brain metastasis of those patients, but in uveal melanoma, we really don't have a lot of good understanding about that.
So when you said that the cells go dormant for like 3.5 months in mice, which is like approximately 10 years in humans, do you have any idea of what could trigger like environmental factors or anything that could trigger them not being dormant anymore? And if you don't, like, how would you go about studying that?
Yeah, that's exactly the question that we are trying to answer. What the sort of the model we have is that there's a factor that's present in the liver that supports the growth of those cells in the liver, and correspondingly, it's either the absence of that factor in the lung, or perhaps even a factor that stops the growth in the non-liver. We don't know what it is, but we have the sort of biology, the tools now to kind of do that analysis. And essentially what we do is we knock out each one of these pathways and see what happens. So do we block liver metastasis? But we can also ask, when we block a pathway, does the liver dormant cell, the lung dormant cell start growing?
Okay.
Yeah.
Maybe my question, for example, with early detection, you know that you have your melanoma. As of now, do we have a therapy which kind of 100% tells you, oh, I mean, this is not going to be, we can prevent the metastasis to the liver because that is the primary target of metastasis. So do we have any therapies which can say, you know what, yeah, I mean, we can prevent this metastasis of the liver, or in this case?
I wish we had that. But as of now, we have no approved treatments in this is called the adjuvant setting. There are studies that are planned to use tebentafusp, for example, or darovasertib in that setting. So we don't know how they'll perform, but as of now, we don't have any treatments that are known to be effective in those patients.